This is the third brain neoplasm presentation, the neoplasm number 3, prepared by Professor Sharaf and revised by Professor Rami Edward. Now, this is the first slide. What we can see here is multiple pattern, and we should know this multiple pattern meant by mass, necrosis, edema, cyst formation, hemorrhage. So this is multiple pattern. Number 2, which you can which you can observe, is the crossing to the other side. Once you have multiple patterns crossing to the other side, you are either with lymphoma or with glioblastoma multiforme. Of course, this is glioblastoma multiforme. We'll repeat again. The presence of a mass, necrosis, edema, cyst, hemorrhage. With crossing means glioblastoma multiforme. In all the following slides, we will find this change. Mass, necrosis, edema, cyst, hemorrhage, crossing to the other side, and the crossing the corpus callosum favors glial tumor is glioblastoma multiforme. This represents a good percentage of glial tumors in adults. Here it should be in adults, because we know that there is a good percentage of astrocytoma pilocytic, the benign form, is there in childhood period. Here now the glioblastoma multiforme constitutes 50% of glial tumors in adults. And remember that you have 3 diffuse forms. Diffuse, that means they are infiltrating. According to the WHO, we have 3. The low-grade astrocytoma, you don't have any enhancement. The anaplastic astrocytoma, you get heterogeneous enhancement. And in the glioblastoma multiforme, you have 2 things: multiple pattern plus minus crossing. Crossing to the other side. Now here, hemorrhage, as shown as hemosiderin. We have multiple pattern. Axial T2 weighted images, large areas of hyperintensity denoting edema and the tumor mass in the left hemisphere. Dark cream lesions in the anterior left temporal lobe and left posterior periventricular areas denoting hemosiderin, denoting hemorrhage. Hyperintensity across the splenium, that's the one. Hyperintensity is seen crossing the corpus callosum. Hyperintensity is seen crossing to the other side, denoting the presence of crossing. Post contrast shows well the tumor mass crossing and show the multiple enhancing lesions corresponding to the areas of T2 hyperintensity, like that one here, and like this one here is seen as hypointense. The central area of hypointensity within the left temporal lesion was necrosis. So we have here foci of necrosis, foci of hemorrhage, cyst changes, crossing, edema pattern. You have multiple patterns plus crossing. Multiple patterns plus crossing. Mass necrosis, edema, cyst, hemorrhage. Mass necrosis, edema, cyst, hemorrhage. Non-contrast scan, CT scan, shows large hypodense mass in the left frontal. Contrast enhanced shows irregular enhancement and shows crossing to the other side across the genome of corpus callosum, and the mass is centrally showing necrosis with thin ring like enhancement, mass effect, and midline shift. Glioblastoma multiforme. Multiple patterns, mass necrosis, edema, cyst, and hemorrhage. Non-contrast T1 weighted image on the left shows a large heterogeneous mass with shift of midline. Contrast enhanced T1 weighted image shows thick irregular enhancement with central necrosis. T2 shows the heterogeneous mass with a large, extensive, invading, crossing peritumoral vasogenic edema. Another case of glioblastoma multiforme with crossing to the other side, showing the mass, necrosis, edema, cystic change, and hemorrhage. This one is the T1 weighted images. Large cystic left parieto-occipital tumor with intramural hemorrhage. Contrast enhanced T1 weighted image in the middle shows irregular ring-like enhancement. T2 weighted images shows cavitary changes, necrosis, high signal intensity, and seen as high signal intensity and solid component of the tumor appears heterogeneous with peritumoral edema and attempt at crossing. Crossing the corpus callosum splenium. Of course, we have two main lesions doing this, is glioblastoma multiforme and lymphoma, but not for deposits. We have cystic changes, we have irregular enhancement. Remember that an abscess has a capsule. Glioblastoma multiforme is invading, infiltrating, and you cannot see a limit for it. It is something invasive, ill-defined, infiltrating, and here it is crossing the corpus callosum. Multifocal glioblastoma multiforme can exist multifocal with again cystic changes, central necrosis, and irregular enhancement in both hemispheres. Glioblastoma multiforme with multiple patterns showing as peritumoral vasogenic edema extensive, crossing the corpus callosum, and irregular necrosis with irregular enhancement in homogeneous at the left basal ganglia region. T2 weighted images shows the extensive vasogenic edema. Diffusion weighted images tractography on the right side up shows extensive infiltration with displacement of the internal capsule. This is the region of the internal capsule, this one. Displaced in displacement of the internal capsule as a region of the tumor. And finally, MR showing increased cerebral blood flow, cerebral blood at the center of the tumor. MRS shows the high choline. Glioblastoma and lymphoma commonly have bilateral spread, butterfly appearance. T2 hyperintensity seen in the corpus callosum or internal capsule must be considered secondary to neoplastic spread because there is no vasogenic edema as the fibers are packed together, so vasogenic edema is usually minimal. In a boy, glioblastoma multiforme with crossing to the other side showing irregular necrosis, mass effect, cystic changes, and peritumoral extensive edema. Now oligodendroglioma is another entity where the main lesion is heavy calcification. The main lesion is calcification. It is a calcified glial tumor. So what are the calcifying glial tumors? You know, oligodendroglioma, some of the astrocytomas pilocytic in 20%, glioblastoma multiforme in rare occasions, and even ependymoma in a good percent. Calcified mass within the periphery of the frontal lobe here with calvareal erosion of the bone and absent edema suggests the diagnosis of oligodendroglioma. So oligodendroglioma is essentially a calcific mass with minimal or no edema. Calcific mass with minimal mass effect, calcific mass with mass effect with minimal or no edema. Another mass with calcification with minimal edema, oligodendroglioma. It's non-enhancing. So the three fulfillments is a mass with mass effect, showing calcification, and usually not enhancing. The cortex here is prominent with obliteration of the Sylvian fissure at this region. There is no enhancement. Compare this one and this one, there is no enhancement, and multiple hypointense foci are seen within, denoting calcifications. Grade 2 oligodendroglioma, heterogeneous, very large, crossing, but there is no enhancement. And multiple hypointense foci are seen, denoting calcification. We have more aggressive form, anaplastic, again with calcification, mass effect and calcification, no significant edema, minimal enhancement. The main key point is the presence of calcification with the lack of enhancement. Oligodendroglioma. The more infiltrative, the more aggressive form is. At the left thalamus there is one with calcification, and here with MRI it shows the hemorrhagic pattern in T1 weighted images here, and it is mildly enhancing in T1 weighted image with contrast. The lesion is oligodendroglioma because of the presence of extensive calcification in CT. Follow-up imaging in brain tumors. We have two main problems in brain tumors. Is that number one, it should be done early within the first 3 days to see if there is something enhancing. It would be residual, or you will be falling in dilemma between being an enhancing residual or being enhancing granulation if you are doing your contrast study after 4 days. But after 6 months you might get diffuse white matter injury, and here there is no evidence of enhancement. Diffuse white matter injury. It is the radiation effect which can occur late, about 6 months after. The second thing is that you can have radiation necrosis. So radiation can either give radiation, diffuse radiation injury, diffuse white matter injury, there is no enhancement, or you can get radiation necrosis, and here there is elevated lactate peak due to necrosis, but no elevated choline because there is no tumor. The majority of the brain tumor do not cause restricted diffusions but show increased diffusion. High-grade astrocytoma recurrence. There is operative interference here. Inhomogeneous peripheral enhancement. Of course, this could be due to granulation if it is done late, but increasing the blood within the area, as seen here, suggests that it is recurrence and not simple granulation. Markedly elevated choline pattern is consistent with recurrent neoplasm because there is markedly elevated choline. There is no prominent lactate. Lactate is concerned with necrosis. Radiation necrosis may have elevated lactate, but choline is increased in gliomas. Here is a large central neurocytoma, which is a rare tumor. Central neurocytoma occurring within the ventricle, one of the intraventricular tumors you might hear about. And the mass is iso in T1 with minimal enhancement. This is central neurocytoma. And lastly, we have the dysplastic gangliocytoma of the cerebellum occurring in young age, keeping everything in place. There is no definite mass effect, but the texture is dysplastic. The cerebellum is dysplastic. It is called dysplastic gangliocytoma of the cerebellum. Thank you.